And now we're going to where the rubber hits the road. So we're actually going to speak to the people who have actually implemented eMMs in the real world and see what their experiences are like. So the aim of this panel is to provide the audience with some insights into how eMM implementation and optimisation is undertaken across hospitals with different eMMs across the nation. Opportunity to share their learnings, so listen intently because these people have gone through the pain. And what I'm going to ask is each of the panellists to first introduce themselves and give us a little bit about their eMM implementation and optimisation experience. So we'll start off with you, Peter.
Peter Barclay,
I'm
the Director of Pharmacy at the Children's Hospital Westmead. So we're obviously part of the Sydney Children's Hospitals Network eMM rollout. But at our hospital, my team and I have also been involved in ADC implementation and also a little bit of work in the closed-loop medication space.
Melissa?
Hi, I'm Mel Baysari. I have not implemented an eMM system.
Are you on?
You are?
Should I speak louder? Yep, okay. I'm Mel Baysari. I have not implemented an eMM system. I'm a Professor of Human Factors at the University of Sydney. I've done lots of this work with Joanna and continue to do this work with Joanna's group. My research group focuses on improving the interaction between users of technologies.
Cool. Erica.
I'm Erica Tong. I'm the Chief Pharmacy Information Officer at Alfred Health in Melbourne. We implemented an eMM in 2018. We've also implemented ADCs that are integrated with our EMR and infusion pump integration.
Hi everyone, I'm Jackie McLeod. I'm from the Royal Melbourne Hospital and I'm the Chief Operating Officer, but that's not why I'm here today. For the last 15 years I've implemented eMM systems, probably from just after Concord at the Austin, and then have implemented the Epic solution at the Royal Children's Hospital in 2016. And in the middle of COVID, we implemented at the 3 other Parkville sites, so Royal Melbourne, Royal Women's, and Parkville and Peter Mac in 2020.
Cool. Daniel?
Hi everyone, Daniel Trajkov. I'm a hospital pharmacist by background, like a few of us here on the panel, and currently I'm the Program Manager at UnitingCare Queensland in the hospital's technology portfolio. But I guess my eMM journey started just over 8 years ago with eMM implementations here in New South Wales in the paediatric space, and then also moved to Queensland where we also implemented the paediatric eMM system over at the Children's Health Queensland Hospital and Health Service. So very much looking forward to sharing that experience today.
And Jerry.
Hi everyone, my name is Jerry Yick, Head of Policy and Advocacy at the Society of Hospital Pharmacists. I haven't implemented an eMM, but certainly can provide the perspective from an end user or a practitioner. But more importantly, it's more about, from SHUA's perspective, the policy, education and regulatory environment that we operate in and how we can optimise that to support safe implementation of eMM.
Thank you. Actually, so first question to you, Jerry, because I mean, obviously hospital pharmacists have been given the job of implementing eMMs in a lot of these organisations. How much training does a hospital pharmacist have in implementing eMMs before they hit the road?
Well, I actually think Erica would have a much better answer to that and give you, at the hospital level, I think there was quite an arduous task, a massive task that she went through in 2018 and beyond. But I think you're right. There actually does need to be a really coordinated training program for all clinicians, so not just pharmacists, but nurses, doctors, everyone that's involved. And it doesn't just end when you get trained up. You actually assess competency going forward as well. And I think that's really important. And perhaps the way that we approach eMM implementation is we see it as a very defined start point and a defined end point. But actually, really, there's a lot of maintenance that keeps going on. And then obviously what we've discussed today, that work doesn't end. And I think it's really interesting as well when you look at what I've been hearing today from both presentations and talking to people outside is in that immediate phase when you first implement an eMM, you're getting a spike in your error rates. I don't think that's really acceptable. Well, now that we know that occurs, how do we respond to that? Because if you look about how we regulate, say, medical devices and pharmaceuticals, if we told consumers, we've got this new medicine, you're going to experience an increase in the error rate from this medicine, that would not be acceptable. So why do we seem to accept that with EMRs?
Interesting, yep. So to you, Erica, I mean, progressing from a hospital pharmacist to a chief pharmacy information officer, what does that mean? Did you need to do extra training in that, or was that just learning on the job and surviving as part of the outcomes?
Yeah, so I had no training when I started my role. Using medication safety principles, and I think that that pretty much gets you through most of it. The technical stuff, you have people to support you with, but yeah, I had no training coming in, but you learn on the job.
Cool. Melissa?
I just wanted to add a comment to that. We did some work where we interviewed pharmacists about how their roles had changed following implementation of e-meds, and the pharmacists talked a lot about how they were now trainers for all the other professional groups. So that's an interesting finding.
Interesting. So, Daniel, because you came in as a hospital pharmacist and you implemented. Did you find that there was did the vendors train you up on how to implement their systems, or did you have to learn on the job?
Oh, look, I think it's safe to say that there were many lessons learned along the way. And, in hindsight's a wonderful thing. If we went back to the start again with all the knowledge we have now, I think we'd be in a really different state in terms of the design of what we're able to implement. I think my reflection is that when we go to try and tackle these implementations, there's often, an overwhelming amount of information that we need to digest and skills that you need to learn. I would actually encourage, any organisations looking to implement an eMM system is try and, almost develop a prototype of a subset of medications that you would look to implement and actually look at the end-to-end process. One of the key things for us, from my experience was, not knowing from a technical standpoint and implementation point of view how the build of a base of a medication would actually impact the rest of the workflow, whether it's a prescriber's view of it or the nursing administration side of things. So even to almost just tackle it with a few subset of meds to make sure that you can actually see the process from end to end and make sure it works before you really tackle the mammoth task ahead.
Cool. And Peter, you implemented it in Children's Hospital, which is a added complexity for the hospital pharmacist is there as being hard enough, yet alone acting thing. What learnings did you have out of that?
I think now, as we are more mature in the systems, we actually have to have staff that can then be part of the governance arrangements. So we have eMM people or specialists as part of the Drug and Therapeutics Committee, also in the Medication Safety Committee, and also some of the clinicians that are working in the complex systems such as the oncology application. We now have a position where we actually have a clinician who's 50% working as that clinician in that specialty and also 50% working with the application. So they're actively working in the system plus becoming an expert in the application. And that's a really important sign of the maturity that we need, because not one person can know everything. But if you're working in a system, you're not going to want to have to click 4 extra times to be able to get to where you want it. So I think you're going to get better results if you have the users also involved in the delivery of that application.
Cool.
But certainly developing those governance people is something we all have to do, because as we introduce new systems, we have to have the right people being able to make the decisions about the management and development of the systems.
Cool. And Jackie, you've demonstrated that there is life after implementing an eMM system. Yeah. Right. So from your experience implementing it again in a paediatric hospital, quite quickly, if I remember correctly, it was quite a big bang implementation of the system.
They're all at sort of no longer than 20 months, even the second one was 20 months.
Mm-hmm. So what can you reflect on your experience and being the first one in Victoria to have to go through that phase? And
I think, I guess the first thing I like is you need a lot of pharmacists.
Right.
But I think there's a few things. Hybrid workflows, I think, are dangerous. You need to pay very particular attention to any hybrid workflows. And I guess the thing that we've done in Parkville for all those is that we have everything went on the same day. So infusions, chemotherapy, there was nothing that was left off. So we had complete workflows, which really meant I felt like we designed it. It was, for me, that implementation felt a lot safer. The other thing I think that is really, really important, it's very tedious, but you must
test every single medication before you go live, from ordering it, printing out the label, getting a nurse to check it, getting a doctor to check it. So it's tedious, but we did that, and that very few issues in regard to build, and probably hadn't done that in earlier installs, but in our later installs, it's absolutely critical.
Cool. Actually, following on from that, because now you've introduced into Peter Mac, so oncology medications are probably the hardest, most complex ones.
So we converted every single protocol. So every protocol was done for the day of live. So that's an extraordinary amount of build to do in a very short period of time. It was all done. It's all and it's and a go live's just the start.
Right.
We've got a team of over 100 staff who make changes to that system every day. And so, during COVID, we were able to very, very quickly respond to change workflows, new medications, and we could do it real time. And we implemented. We could have picked a worse day to implement. It was the day that we had the most COVID patients in hospital. So,
life wasn't meant to be easy, they say.
No, it wasn't.
Good. So you make an interesting point. Feedback from the floor about implementations. Peter, when you implemented this at Children's Hospital, what was the mechanism for getting real-time feedback so that the back end could be fixed up?
I think it's from the eMM team that are working with the clinicians. So they're the ones who have the skill with application, and they're actually at the elbow of those clinicians being able to support them. Yeah. So I think that gives those clinicians the confidence as well to know that they are supported and they are being listened to.
Right. Erica, what was your experience with that? Again, how to get that feedback to make the changes needed?
24-hour at elbow support, probably for the first 2 to 3 weeks of go live, I think is really important. That you can identify which things are actually errors in your system versus teething issues, or clinicians just need to get used to it and it is the new normal. But at elbow support, definitely.
Cool. Daniel, what was your experience there?
Look, I think, reflecting particularly on the implementation at Children's Health Queensland, I think that our clinicians were so entrenched and embedded in the project, and so they were engaged really throughout that implementation journey. But during the actual go-live itself, it was so imperative that we actually included clinicians in those review and feedback sessions, so, not just sort of confining it to your project teams, but often what we would find is that on the floor, as you have floor walkers and at the elbow support, there's so much feedback that you capture, and it's so challenging to actually make sure you collate all of that information, synthesize it in a way that's meaningful to feedback. But what I think was so important from my experience was actually having our project teams and representatives from the floor, clinical representatives, that could actually look at these themes that were emerging and actually start to put action plans together on what we could actually change in an agile way. So I think that was a key part of our success.
Cool. So to you, Melissa, do you want to comment on that or no?
Now is it working?
Yes.
Okay. I just wanted to comment on the interviews that Joanna mentioned because I was on the floor undertaking the interviews, and also comment on Jerry's comment about how drugs. I mean, these are not drugs, these are very complex systems being implemented in very complex socio-technical systems. It was the anxiety and stress levels, of shifting from the way you work entirely from a paper-based to an electronic system. I mean, it's just not comparable to a drug. So I wasn't that surprised when the error data emerged, just from my experience of being there on the wards with the staff. So it really is a complete change in work. These systems really do change work.
Cool. So following on from that, I mean, we just saw some examples of technology-related events, and I had trouble seeing some of those things on a 10-foot screen, yet alone on a 12-inch screen. From a human factors design, how much of that has gone into eMM design? Is that an area? I mean, we keep on hearing complaints that life's so much easier on my iPad. Why can't it work like that? But in reality, the systems aren't designed that way. Any comments on that?
Yeah, I think people also, as we use so much technology in everything we do, we have high expectations from technology. And I think that's really what people expect from health technologies, but health technologies are not iPhones and iPads. They also have to support these very complex processes, and something like medication management. I mean, there is a lot of room to move on making these systems more usable, definitely. And I mean, I don't think I've ever seen a system that's perfect. I don't think there's such a thing as a perfect system anyway. But yeah, so we do have a lot of room to move on usability, and it was great to hear Mark's talk about the work they're doing initially in design. So I think we could do a lot more early on, and then it's a continuous process, I think, of optimising design of systems.
So anyone who's actually implemented one, would you have any comments on how that's been changed?
Because it's not just about the technology. You have to pay so much attention to the workflows. So we've implemented, so our nurses do have handhelds, and they're designed for bedside activities, and so it's around the whole process. And I agree, it's a very complicated process, but you've got to make the right thing, the easy thing to do. So for me, I think the systems have come a long way. Like from when I was implementing in 2010 to what you see now, they are streets apart, in terms of what's there, and some of those factors have been picked up. But you can't pay too much. You've got to. It's so much attention about the whole workflow and where things are placed. Where are the drugs? Where are the? How does a nurse interact in the drug room? Where are the label printers? So that's what's really important, because it's the whole system it's the human acting with the system, trying to support that very long workflow that you really have to pay particular attention to. It's not so much this. I mean, the system's important, but.
Just also make a comment on that. In that, I do a lot of qualitative work with healthcare professionals, and often I know how the system works, and what they're telling me is the wrong. So I'm not saying that training is the solution to everything, but it's often the case that they just don't understand the functionality to the level that they could.
Mm-hmm.
So,
Peter?
I was just going to comment on the workflows, because quite often it's sort of a root and branch review of all processes happening within the hospital, and you uncover all sorts of things where you need to discuss with the senior nursing staff, etc. Not every problem is an eMM problem. There are problems that exist because there was poor practice. So that has to be teased away from the eMM process.
No, I think that, because as we look at workflow, I mean, it's obviously only as good as its weakest link, and as Joanna pointed out earlier, things like double check taking 6 minutes in a workflow throw out all the efficiencies. When you document your workflows, I mean, you started off with what was considered to be normal, or did you observe first what was actually happening on the floor and try to adapt to it, or did you just sort of come in saying we're changing workflows across the board? Daniel?
Look, I think the first principle that we really tried to adopt was we're not digitising paper. Oftentimes we look at our current state processes, and there's reams and reams of forms and documentation that we capture a lot of information on. And if we just try to digitise what we've captured on paper, it's not necessarily achieving the outcome that we want. So I think that was the first principle we really tried to establish. So then it's really shining a light on business process, clinical workflows, to understand, what is the, and almost challenging some of the things that we're capturing. Should we be capturing all of these, parts of the assessment or at the point of admission or things like that? So it's actually, it's almost like you're not reinventing, but you're actually taking an opportunity to look at what we're doing from a clinical perspective, and actually trying to transition that into a digital world, but not digitising paper, and that was the key thing from my perspectives.
Cool. Erica, any comments on that? I see you.
You're right, Dan. It's around redesigning workflows with a digital system, and not just replicating the paper workflow in a digital world.
Mm-hmm. Whereas very early on, eMM implementations were basically just making a digital medication chart. It was taking it off a paper and making it print out. So that's changed. But another large part of the whole eMM side is the supply side. What happens not at the ward but in the back end. To what degree has eMM made the back end work of pharmacists more efficient, more effective?
So I think that it's allowed pharmacists to see when new medications are prescribed. So, in the past, you left the ward at 3 o'clock and walked maybe to another ward, and you wouldn't know that some critical medication had been prescribed for a patient. Whereas now we can alert a pharmacist that a high-risk medication has been prescribed for a patient, and they can, go review that, ensure there's a supply, the dose is correct. So that's completely transformed the way clinical pharmacists work. We can also have interfaces between the EMR and dispensing systems, so there's no more manual dispensing, which reduces error and risk. And nurses can request supply of medications through the EMR as well, and there's accountability, and you can track. The nurse requested it at 3 o'clock, the pharmacist reviewed it at 3:05. It's on the ward at 3:30. So yeah, I think it's completely transformed that.
Comment on that, Jerry?
Look, I think just as Erica is describing, I also work at the Alfred where Erica, so she's sort of my boss, so I often I worry when I'm dispensing medicines, there's a timer in there as to when it's been ordered, when it's been charted, and what time I supply that medicine, so hopefully no one, picks up on me, when there's a critical medicine. But I think that's also been really helpful for pharmacists and all clinicians really to triage their work and prioritise the work, especially nowadays where we are seeing a lot of more complex presentations and shortages in our workforce. That's one of the benefits of EMR beyond all that we've described so far, is the ability to really prioritise our work, because that's really much needed in the current setting.
It's interesting because I'm old enough to remember when JMOs had to break into the hospital pharmacy at 3 o'clock in the morning to get medications for the ward, so things have changed obviously in that regard.
I was just going to mention sometimes there's too much information. So at a smaller site where you don't have people sitting in front of a screen continuously, the various monitors which show the new orders, it can be a bit overwhelming. So you, as clinical pharmacists, do have to learn how to most efficiently use the system. But certainly having the information down in the dispensary and available everywhere is fantastic. But because a lot of the systems were designed that would have pharmacists sitting and staring at a screen the whole day, we are not working that way in Australia. So there still needs to be a bit of tweaking to manage the volume of information, which sometimes is extraneous to the items that we want to concentrate on.
Cool. And to your point, Jerry, hospital pharmacists still are, a valuable resource, which is not easy to get your hands on.
And I spoke with my team before I was coming up, and I said, what are the big things have changed? And it's all of those things of absolutely being able to prioritise their work. Is one of the things they said to me is their dispensary is quiet. Used to be like, phone calls all the time, and so because we use secure chat, which is another part of the, so it's not like that anymore. And it's the other thing for those of you who work in hospitals that post-COVID access to our services is we've never seen demand like it. And so some of the things that we've been working on with pharmacy in particular around pharmacy-led prescribing in a much bigger way than we've ever done it before. We've been doing a bit of a trial and looking at the accuracy of medical prescribing compared to pharmacy prescribing, which is pretty amazing. But and now I've got about 4 or 5 informatics pharmacists. The amount of data that we have, the supply issues that we've been having. I'm sure we're all having supply issues, and the ability for us to be able to see where those medicines are being used, which doctors are prescribing them, where there's variation. We would have never been able to do this 2 years ago. So it's just really changed. And I think the pharmacists, there is a change in their roles, I think, when you go live with EMRs, I think.
Yeah, I think there's certainly, in hospitals, because we do get that massive turnover of JMOs every year, I think pharmacists in hospitals do take a really strong role in medicines compared to the primary care sector. So they're educating nurses, they're educating JMOs, they're teaching them how to use, be it the EMR or the paper-based medication charts. So they certainly there is a larger role for them there. So they're really critical to the success of these implementations as well. And I just also want to touch on what you described there around partnered pharmacist medication charting as well. Really, Erica's led that work in Australia. So, but look, that's been a lot of been fantastic in Australia, and certainly I guess that's how it now interfaces with eMM systems and EMR systems, because that's sort of been implemented. Whilst we're in this flux of using paper charts, but also electronic medication records as well.
Mm-hmm. So one comment I'd make: most of you all seem to come from large tertiary referral type hospital systems. So you have a pharmacist on site, you have quite a diverse skill set on site. How does this reflect back to smaller regional hospitals or even community hospitals in metro areas? I mean, can they leverage the fact that they can use the eMM from a tertiary hospital in their organisation?
It's interesting. I did a review for a regional area around it, and they said to me, "Oh, we don't want a full EMR." And I said, "Okay." So which part of your hospital are you not going to, you still have an operating theatre? So I actually think they do need they do need this sort of breadth. And I think the systems do support those areas. It's just that we haven't tackled that just yet. I think that the systems are designed to be able to be used in smaller hospitals, but we just haven't tried it yet.
Right.
In Victoria in particular. I don't know if you've done it in New South Wales. You've probably done it more in New South Wales. But
I guess in Victoria, the way that our health service system is designed as well, it's really, really decentralised as well. Whereas I think in New South Wales, you've got, more structured networks with your LHD network, so it might make it a bit easier, or you've got the structures and support structures there to support that.
So Daniel, do you have any experience across area health services? So again, I mean, obviously Children's Hospital, there's 2 tertiary referral hospitals, but Southwest Sydney has big Liverpool, and then Camden with 30 beds and struggling for staff. How does that system work in that sort of space?
I can certainly reflect on the state in Queensland, really, where they have a shared EMR across the entire breadth of Queensland in the public health system. And I think one of the things that I really, moving from in New South Wales, where we had our complete autonomy almost with our individual instance of the EMR, and we could do all sorts of config change, to a system where it was a shared record across the state. Queensland Children's Hospital was had a catchment of the entire breadth of Queensland, length and breadth of Queensland. So having patients that were being retrieved from regional centres and having that information immediately available to our clinicians, whether that be in the critical care space or in the inpatient areas or even in emergency departments, is just invaluable. I think that the value of that can't be underscored.
Just another quick comment, not to hijack the topic, but on your point around regional services and small services, so in Western New South Wales LHD and Far Western New South Wales LHD, there's been a project called the VCPS, or the Virtual Clinical Pharmacy Service. So these are really small sites that before COVID didn't have a single pharmacist on site at all. So there was barely any discharge counselling, barely any medication reconciliation. But because they do have Cerner, you do have eMM and EMRs, they've been able to have a virtual pharmacist that could be based at a completely different LHD, dialing into, using teleconferencing facilities to interview the patient, and then also accessing the EMR. So they can actually now finally provide clinical pharmacy services which weren't ever provided before, and really improve the quality and safer use of medicines. So I think that's also really, where it can be implemented well, like it has been in New South Wales in those regional rural sites. That's really where some of the benefits that you can really demonstrate.
Cool. If anyone has any questions, please raise your hand. We can raise those. But another challenge we face is that medications within a hospital are managed well through an eMM, but patients have lives before and after hospitals. Continuity of care. How well do eMMs currently manage that pre and post? Is My Health Record a benefit to an eMM in that you get some medication data coming in, or?
Yeah, I think there's certainly, I know there's some ADHA colleagues here. So we have to be really careful in what I say, but I think it's fair to say, and we've said that to ADHA before as well, a lot of their initiatives have really been focused primarily and firstly on the primary care sector, and that's okay. We accept that the bulk of healthcare in Australia is delivered in the primary care setting. So it's understandable that that's really where the focus is on. That said, we would certainly appreciate a lot more focus and understanding that a lot of the states and territories are embarking on the EMR journey at various different stages. You have high degrees of variation that you would never ever see in the primary care sector. And so when the Commonwealth is ready to, okay, let's introduce this in the hospital settings, we're actually we're having a really different conversation here. When you say electronic prescribing, that means something completely different in a hospital. So I think that's a constant challenge for us, but keeps me in a job really.
Cool.
I think it's also really important to, in the hospital setting, we have great data about what happened to the patient during their encounter, at what time they had their paracetamol, who are the 2 nurses that checked it. If they get a PBS script or a paper discharge script written, that information may get scanned in, but it's not part of their record. So hospitals are only one part of the process. Patients live outside. To keep ourselves relevant, the hospital systems have to make sure we capture information and events that happen, like a authority script that's written at an outpatient appointment, that needs to stay both in our hospital record and get out into the outside world. Right. So we have to embrace e-prescribing with prescription registers, etc. So we're just part of the same system. because that information that's collected in our hospital EMR will then be available for the next clinician that does a encounter with that patient. So they'll know what their home medications are because it's been recorded in the hospital eMM, and then can go out into the My Health record as well.
And in the defence of ADHA, they're working on electronic prescribing, and your dispense records can be uploaded to the My Health record as well. So that's actually been so beneficial for our hospital pharmacists when they are doing medrec, or nurses and doctors doing medrec, because you can, instead of interviewing the patient or calling up the community pharmacy and disrupting their work, and we hear about disrupting work causes errors, we can just see that off the record. We're also working on the pharmacist shared medication list as well, so we can curate a medicines list upon discharge or at any healthcare episode.
Okay, we've got a couple of questions from the audience. I'll start off with Jeffrey.
Thanks, George. I'd just like to explore a couple of aspects of something I haven't heard as much from the panel about, which is about the interface of technology and culture. So first question is to you, George. You've queried my aptitude with clickers. So mostly that was a technological problem rather than operator error. And shouldn't we get to the stage where we don't blame the operator and run a non-blaming culture?
Valid point. Any comments on that?
Now a much harder question to the panel. So what we're essentially doing is implementing a complex adaptive system into another complex adaptive system. And there's different characteristics of the complex adaptive system that we're calling the hospital that we're implementing this other complex adaptive system into. So we know from lots of research that hospitals differ in culture. And some are receptive to change and kind of reasonably good at it. There's no nirvana. They've all got problems. And others are highly toxic. They're full of pathology, psychopathologists, None in New South Wales, by the way. This is about other countries.
What state isn't represented here today, so we'll blame them.
So we know, and I'm not dichotomising, there's not good hospitals and bad hospitals, they all have their characteristics, but some have problematic cultures and some have more receptive cultures. What's your experience or guidance on dealing with different kinds of cultures where we're trying to do this complex implementation?
Can I answer that?
Jackie's probably a good one to start with it.
Culture is so important, and I don't know if anyone's a member of the Arch Collaborative, but there's a very strong link between positive culture and outcomes. And I've said, having done sort of 5 hospitals now, all very different cultures, some harder than others, and you'll get different outcomes at each of those. And I guess the way that I've tackled in the past is, we can all say it's not a technology problem, because it's not, but it absolutely is it's absolutely about how you engage from the top to the bottom, and making people accountable, I think, and really having accountability through all layers of the organisation. And my last implementation was really interesting because I was doing 3 different hospitals at the one time with very different cultures. And actually that was quite interesting because what I found is, I think that the can-do-it culture of one of the organisations really helped the other organisation, which are a lot more risk-averse. So I think that having that group together was actually a really good thing for the one that really struggled, and the learnings from the other group were very, very. But I can't tell you how much the CEO, the executive, the chief medical officers, the meeting with every single unit head, all that sort of stuff. That's what makes a difference.
Melissa, you had a comment on that?
Yeah, I just was going to provide an example because my PhD student Bethany's in the audience, and she's looking at the use of the same technology across multiple hospitals, even within a district, and the differences are absolutely amazing. Like, it's exactly the same technology, but the
system is being used in completely different ways to support different processes, and so it just says a lot about that it's not really about the technology in the end, it's about how the technology fits. Yeah.
And again, George,
Mark may want to comment on that.
Look, I think we've got some notes to swap. So we had the pleasure of joining the class structure. So the reference to the Arch Collaborative is the US company that, after I think 20 years of clinicians berating EMR vendors that they didn't know what they were doing, they set up this clinician practitioners, so all practitioners or care deliverers surveyed on the qualities or not of their particular system. So New South Wales, after I wanted it in my first year here, 2019, but something got in the way, we finally went live with it last year, right at the go live of a whole bunch of vaccination hubs, which just got past the secretary, which is okay. 6,000 of our staff answered. So again, I think, Mel, from those, even within those, so each district and network own their own class results. We went back to each chief executive and the stories behind what they could see, even from relatively a simple clinical response rate. And just to pick up on that one from last week, we had the absolute pleasure to host for the whole week the class team, members over from Intermountain, members over from Kaiser Permanente, members over from NHS, and we had a lovely Arch Collaborative with our presentation from Royal Children's Melbourne, as well as the Children's from Queensland. It was a phenomenal week. Just one comment, again, to Jerry's early reflection. I think we got to mid-Wednesday before anyone even mentioned tech. The thing that occupied us for 2.5 days, and then a lot more after, was the whole environment, the new world order of education, training, coaching, mentorship, career, professional life learning, and what all this means. I was getting a little anxious we weren't going to discuss tech at some point, but just that environment, and again, it was lovely to hear all of these thoughts and considerations. Just on the rural, for the question around the rural team here through the EMR rollout to the 200 sites, they actually went further than even their metro colleagues and created the first unified rural formulary based on their perception that they needed to unify. Having a disparate number of different rural formulary structures would just not, they felt, be tenable. It predates me, so I cannot claim any form of credit, but absolute power to their ability to see. And I think that comment of, it really is that ownership. It's the leaders and also those who deliver care. This is their system. This is their tools, and it must therefore work for them. It's not the other way around. And I think that shift in culture of why does it do it this way, and even that comment earlier on from our colleague from Concord, but why, if I want to do an IMS or an incident, why can't I do it in less than 5 seconds? Maybe in less than 1 second. I don't want to spend X minutes. And I think that's just but one example. And I think that's that shift in balance, and obviously then I become a humble servant to all of you, is how do we ensure that that's what it does, rather than we pick a solution off the shelf and then vendorize it to the system. This is what you've got, it's the only thing you're going to get. And one last comment, you've raised a red flag to me, so I can't obviously discuss procurement, but just to ensure for the audience here, the vast majority of those engaged in the procurement currently for New South Wales are clinicians. So they dominate the evaluation panel, they dominate everyone who's been engaged. So I hope that would be succor to the clinicians, practitioners, that it's actually their representatives, and hopefully some of them as well, who will define the next generation, at least in New South Wales, and I'm sure that was echoed in some of the other states.
And I think that's a major change compared to when the early days. Last question over here.
Thank you. Madeline Gazarian. I'm a paediatrician and clinical pharmacologist, and have been a member of the steering group for the research that Joanna's reported today. And look, I've got 2 comments and a question that's been prompted by some of the issues that the panel's raised, and George, you as well. The first one, and these relate to, in particular, implementation and optimisation for the paediatric population, regardless of where they may be within the state or nationally. So the first one referring to the system as a whole and how people function within the system, and there's been reference made to training and education and the skill sets of the people using the system. And most of the time, I think when people are talking about that, they're referring to training for how to use the technology. But I would make a suggestion that the core training of safe prescribing, and in particular safe paediatric prescribing education, needs to be incorporated into the future implementation design. That's the first comment. The second, with regard to the generalisability of systems developed within tertiary paediatric settings in other settings, I would make a strong plea for those who make these sorts of decisions to enable the kind of comprehensive evaluation framework within which this implementation was conducted. And I think that that would be even more important for the smaller centres, to have that framework within which the implementation is conducted, because the issues will be different to some extent, and to be able to detect those quickly and address them effectively will be really important. And again, even more so for keeping the paediatric patients safe in those settings where the underlying skill set is, very different to what's in the tertiary centres. So the question part is, do you think the healthcare system can enable that kind of research to be conducted without another NHMRC grant needing to be got?
I guess do we embed that in research culture into the organisation's comments?
Well, I think certainly one of the key success factors from my point of view is making sure that you don't just implement and then move on. There's definitely a need for data-driven optimisation, and I know that the term optimisation is often used quite loosely, but in a true sense, it's actually keeping teams in place and maintain for a period of time where you can actually continue that journey. So I'll give an example. In some of the initial pediatric eMM implementations, there were some really complex high-risk areas in therapeutics such as blood products and pain infusions, metabolic infusions, where it's just incredibly complex to tackle that at the outset. But you definitely need to have a plan to actually digitalise that workflow. And so, there needs to be that forward thinking and not just sort of keeping them in the too hard basket. But certainly I think there's a need to use data to drive a lot of our decisions around design and redesign and optimisation. And certainly when I was with Children's Health Queensland, we did use a lot of that data to actually look at what was happening out on the floor. What you train and what you implement is often very different 6 months later. So you do need to actually go back and look at what is actually happening, what are the themes that are emerging, and actually respond to that. And actually, from not only from a system redesign perspective, but from a, whether it's be training and re-education components as well.
Okay, anyone final comments on that question?
Oh, sorry, Mel. I was going to say, I agree with Dan about using data and some of the work, Mel, you've done around alerts and ensuring that you're looking at what alerts are being overridden by your clinicians and reviewing what you actually have set to fire at your clinicians in the back end.
I was going to just add that I think data is very, very powerful, but that doesn't tell the whole story, and I think we should be talking to users and looking at how work is done, because it doesn't tell you, for example, whether something's being worked around or if people are becoming frustrated or whatever.
So eMM and hospital pharmacists still have to go on the ward and watch what's happening and be actively engaged in it. Please join me in thanking our panel. I'm sure they'll all be available over afternoon tea to answer any questions.